You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is April 6, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, Allergy Journal Club. Our presenter is Dr. Nikita Raje. She's an Allergy Immunology Fellow at Children's Mercy Hospitals and Clinics. We're going to shift gears now and have an Allergy Journal Club. Dr. Raje is a first-year fellow here in Allergy Immunology at Children's Mercy, and you're going to talk with us about two articles. So here's your presentation. So
okay.
Take it away, Dr. Raje.
All right. So, can I have some?
Here's the mouse.
So my first article is the ability of adults and children to visually identify peanuts and tree nuts, and we'll allow some time to finish the quiz. This is just a quiz. This is what they had displayed for the study, and asked the participants to identify all these nuts.
Identify what kind of nut?
In different forms, and like shell, non-shell, like all those. So we'll just have everyone fill that up.
So we're supposed to
and
rate
it can be,
what kind of nut it is.
Right.
Oh, cool. Okay. And the guys online just sort of make a mental note of it, or maybe you can write it down yourselves. Okay, some of these are
double. Yeah.
They're all double?
Yeah. Well, yeah, they are different forms. So.
Oh, wow.
I know, because I was like, can't be that many different. I know, but it's a terrible thing. I know, I'm trying to see. I didn't even know some of the names because I'm going to put that in there. It's the only one I'm not going to guess on. Well, then you should recognize them all. Oh, wait.
For some reason, for some reason I lusted for these things. Like I wanted to. I slowly started eating them because I just wanted them. But for chocolate, I just never wanted to. I don't know why. It was like the Truman Show, you know, where he has to just go on faith and assume he knows what he's doing. And that's what it's like. I just went on faith, and I
not
bad.
Guess I'm not that good at nuts. But it is something we should probably be familiar with. I agree. I bet Charlie Barnes knows all these nuts. You know the answers to all these ones, Charlie? Oh, we can't hear you. Sorry.
I guess. Are we all done?
No.
No?
Because done is all being.
Yeah. I can go. Yes. You want the answers first? Yeah! Yeah. Okay.
Well, why don't we go through them? Who knows what number one is?
Cashew.
Cashew.
Yes.
Cashew, okay. Number two.
Number two. Yeah. 3. Pistachio. Yeah. 4.
Bill?
Brazil. 5. Pomegranate. Yes. 6. Chestnut. 6. Chestnut. Anything else? 6. The pecan in shell. Oh, really? And you know, if it's made like by itself instead of a picture, it might be a little more clear, but still. 7. Walnut.
Like chocolate.
Yeah. Okay. 8. Peanut.
Yeah.
9.
What is it?
Pecan. Drop. Drop.
That's not fair. You can't chop them up.
I took the test and got them correct. Oh, what did you say?
Charlie Barnes, she got them all right.
Walnut.
He's from Georgia. So a lot of nuts down there.
Then, pine nut. 11. Almond. 12.
Peanut.
13. Yeah. That was
It's like a pistachio.
Yeah. 14. Can't remember that one. That's watercress. Brazil nut in the shell. Yeah, 15.
Max was 15. Means what? Pecan.
Walnut. Yeah. 17.
What's 17?
Brazil nut in the shell. Which one? Did that one. Which one? 17 is walnut. Walnut, yeah, in the shell. 18. Spanish peanut. I don't even know what that is. That's hazelnut. 19.
Yeah.
And 18 or?
Huh?
Walnut.
19's walnut.
Yeah. But at least someone knew, like all of us, I think our statistics are better than we'll see. Alright. So
It'd be a good Jeopardy thing, you know.
Yeah. That can be on our board.
The pitfall.
That'd be a lot easier than falling. So, right. So just some introduction. Peanuts are most common allergens among the adults and children. Can cause particularly reactions and are a leading cause of food-induced anaphylaxis. The only preventive measure is dietary avoidance of the food allergen and the cause. And from one of the sources, one of the references of the patient, peanut allergies, reaction from X in a 5 months. The ability to visually recognize the peanuts and tree nuts is essential for successful avoidance, and the goal of the study was to describe the ability of the children and adults to identify and differentiate peanuts and tree nuts by displaying the nuts in commonly purchased and used forms. So this was interesting that they got the approval from Behavioral and Social Sciences, IRB. They also got the formal oral informed consent from all the research subjects. So the nut display with 19 numbered compartments displayed peanuts and 9 different tree nuts in commonly purchased and used forms. Each form of the nut was randomized to a compartment in the nut display. You may be changing it. And these were the different forms of nuts. They are in random order, not the exact order that we went through. And we already went over those names, so I'm not going to go over again. So the recruitment was done at Center of Science and Industry in Columbus, Ohio, and any English-speaking person 6 years or older without known neuropsychiatric condition or developmental delay who visited the center from March 19 through 25 of 2010, and then on April 3rd, so about 8 days, that they were all eligible to voluntarily participate. Some demographic data was obtained from the participants. If they were between 6 to 15 years age, they obtained, they noted down the age, sex, and whether they had any personal history of allergy to peanuts or tree nuts, and if they could tell them which specific nut they were allergic to. If they were 15 years or older, apart from this information, they also asked them if they were parents of the children who were allergic to tree nuts or peanuts, and their job description, if they could give them. So whether they were in child care or teaching, food preparation or serving job, or patient care, in health care related. So after getting the demographics, they were asked to visually identify each nut in the display by writing the name in the corresponding area, and they were okay with if the name was spelled incorrectly, as long as the person interpreting them knew what they were talking about. And then primary analysis used in the study, they used either Wilcoxon rank sum if there were two groups, or Kruskal-Wallis type of analysis, both non-parametric analysis. They used Data 10.1 software for the analysis. So going over the results, a total of 1,105 subjects ranging from 6 to 87 years old were completed the study, and 649 were adults and 456 were children. So they noted that the adults, when they compared adults to children, adults identified a mean of 11 nuts correctly compared to about 5 nuts for children. So this was significant with p-value of less than 0.001. When they compared females to males, it was again significant, 9 for female and 7 for male. So not a big difference, and pretty much if we think about it, out of 19, still the best was 11, even for adults, so it wasn't that great. For all subjects, 8 was the mean number of nuts that they identified correctly. So this is just the percentages of each nut that was identified. And for the peanuts in shell and without the shell were the most commonly identified. Next came the cashews, and then least were like the hazelnuts that were identified. And if you see the dark gray bar is for adults. So for all of them, mostly the adults did better than the children. So 94.7% correctly identified the peanut with the shell, and 80.5% without the shell. Cashew was 76.7% participants. Hazelnut was 16%, whether it was in the shell or out of the shell. So the mode was found to be 3 out of 19. So 3 out of 19 nuts were correctly identified by most of the participants. Only 1.9%, so that was 21 subjects, correctly identified all 19 forms of nuts. But that was pretty, 1.9% only identified all of them. So there was a direct correlation that was noted between the age and the mean number of correctly answered nuts. And they used the Pearson correlation, and it was found to be 0.637, which was significant. And if we go through each age, as the age goes up, the mean number of correct nuts were increased from 3 to 13. So then they looked at whether the allergic adults did better job at identifying the nuts. However, they found that it was not significant. The p-value was 0.104. So the allergic adults identified about 13 nuts, and non-allergic ones 11, but this was not significant. So there was not a big difference. Similarly, for allergic children and non-allergic children, the difference from 6.5 to 4.6 was not significant. So it didn't matter if they were themselves allergic, they still didn't do a good job. And again, the difference between allergic adults and allergic children was significant, so adults did better than children, so it didn't really matter because even the adults without the allergies did better than the other children. So again, if they combine the adults and the children, allergic subjects did not do better than the non-allergic ones. The p-value was 0.465. So they had the information whether they were the parents of allergic children, and they saw that the parents of allergic children did not do better than the parents of non-allergic children. The p-value was 0.081. However, they looked at if the adults were parents or the adults who did not have any children, and they did do the adults who were parents did better job than adults who did not have any children. So the p-value was significant there, 0.001. They also looked at the occupational history, and they found that if the subjects worked in childcare versus had not worked in childcare, they did better job at identifying the nuts. Again, the subjects who worked in medical field did better than they who did not work in medical field, and the p-value was significant. However, if they worked in food service, it didn't really matter. They still did the same as the subjects who did not work in food service. And here's some information whom they included as child care, so even teachers, scout leaders were included in child care. For food service, they looked at chefs and food preparation, catering services. Medical service, they looked at physicians, nurses, dietitians, and nutritionists. And the form in which the nut was displayed also made a significant impact. The peanut in the shell was correctly identified 92% of by 92% of the children, but only 63% of children were able to identify it was without the shell. 69% of the participants identified the whole almond without the shell, compared with only 37% who identified the slivered almonds. 45% identified pecan whole without the shell, but only 18% identified in the shell.
So kind of in Ohio?
Yeah.
They don't have boiled peanuts up there. It's usually a southern thing. The size that you'd recognize them boiled and not out. So like a shell.
I don't know if you had noticed that Quad AI, there was this one poster where they had this display and they were asking everyone to write down the HV. Sorry, did I miss the slide? Yeah. So they noted the strength of the study was that there were a large number of participants. They were able to display the nuts consistently, and the ability to display the nuts in multiple forms. The limitations they noted were that it was performed in one city at one location. They could have had a selection bias. So there were a lot of people who walked there and refused to participate because they thought that they would not be able to perform well. So that was one of the biases that they noted. The nuts were displayed in plain sight in their typical forms, but in real life they could even be more difficult to identify because they could be mixed into the food and with topping in the desserts or something. This study did not display every possible form of nut a patient may encounter. And they noted that 2.4% of their study population reported an allergy to nuts or peanuts or tree nuts, but overall the peanut or tree nut allergy is estimated to be 1.2 to 1.4 in the United States, 1.4%. So they think that they actually overestimated the allergy. So conclusion, they concluded that both adults and children are unreliable at visually identifying most nuts, and it's independent of age, form of nut, work history, or peanut or tree nut allergy status. Allergic subjects also are poor at identifying all the forms of the nuts which they are allergic themselves. So they suggest that the treatment of peanut and tree nut allergies with dietary avoidance should include education about the identification of peanuts and tree nuts. So that's my first article.
That's very interesting.
It would be nice to have a big poster in the clinic. You can say, this is what you're looking
That's what I thought about, that we should actually have success.
I mean, you give all the fan stuff, and if they get on it, I'm sure there's pictures of everything, you know, but it's a matter of whether they use it.
Whether they go to that website.
Yeah. Might be interesting to do an allergist.
So, yeah.
Do an allergist to study an
Yeah.
allergist and see how many of us.
Won't be any better.
Yeah.
Yeah, I don't think we'll be any better.
So how important do you think it is that people with nut allergies know what the nut they're allergic to looks like?
That's what I was going to say. I don't know clinically if it's discerning between the nuts is as important as knowing if something is or is
So
not.
I have that data actually, I didn't put it up. So they had the
I
information.
think it's a pecan or a hazelnut as long as they know that that looks like a nut and they should avoid it. You know, like that's why I don't understand why would you care if they could discern between that? If they wrote pecan instead of hazelnut, but they would still not eat it either way. Why does it matter?
So if you're talking about if we tell them to avoid all tree nuts, is
Yeah,
that what you're
I
saying?
always tell my tree nut.
But I don't think every allergy practice does that. And even among our departments, there are people who say, okay, if you can identify and if you know that this brand works for you, for a lot of patients, we tell them that you can still have this specific nut, or
Like if they said they ate macadamia nut without any problem.
Right.
But they had peanut allergy. Yeah.
So I have actually for this study, 20 of the 27 peanut and tree nut allergic subjects specified which nut they were allergic to. Only 50% identified all the forms of that specific nut from the study. And then for the parents, 15 of the 20 parents who mentioned that they have children with the allergy specified the nut, and out of those 15, 73%, 74% correctly identified all forms of that specific nut. So it's still not, 100%.
So do you think it's important that people know what the nut they're allergic to looks like,
I think so.
as opposed to just avoid nuts?
I think if you're not going to avoid all nuts or whatever, then they're selecting them. Then I think it's important to know that.
Yeah.
But once it's chopped up or processed, you can't really tell them apart because inside the chopped nuts all look the same.
The store-bought cookie is going to be hard to figure that out.
And most nuts come as mixed nuts, so they're all kind of mixed together anyway, and then the dust from the nuts are all. So it's sort of like if a patient's allergic to ragweed or Johnson grass, we don't insist that they have to know what a Johnson grass looks like. So we don't do it that way. But I guess with the food it's different because it's not hay fever, it's anaphylaxis, plus you can choose whether to eat the food. With Johnson grass, you can't choose whether to breathe its pollen. There's a Johnson grass pollen. I'll not breathe that one, but I'll breathe this pollen's okay. It's not the same. So, I don't know. What do you think?
I just think discerning between the nuts is as important. If you're going to undertake the task of eating specific nuts other than one you're allergic to, then I would imagine it's a little bit incumbent upon you to either be able to inquire, is this nut in that food, by reading labels, or at least know what that nut looks like,
Should we develop color handouts like this that are labeled to hand to our not allergic patients? As part of the food allergy.
Them avoid all nuts, and that's not as important. It looks like any of these are.
I mean, I think it's really important that they be able to tell what's a nut and what's not.
Yeah.
But I don't know if they wrote pecan and it was really Brazil, do I care? Like,
it would be interesting to show them pictures of things that may look like a nut and may not. Like,
exactly.
These chopped up pieces of pine nut, like that. You might not look at a pine nut and not know that's a nut because it's just like this little white slivers or a seed. Yeah.
It doesn't really look like a nut.
You could do that.
So do you think we should have a handout like that?
Versus other nuts, because sometimes if they are allergic to tree nuts, we say, okay, it's okay to have peanuts.
Yeah, go ahead, Brock. What did you want to say?
Oh, well, there was something on the news the other night that really kind of irked me. This girl was so sensitive to peanuts that if her boyfriend ate one, it could kill her. That was on the news the other night, the local news, which, I go, oh, whoa, wait a minute here.
Well, there was a report of somebody who kissed a person who had eaten peanut, and there was still enough peanut in that person's mouth that when they kissed, there was enough ingestion to cause a reaction.
Yeah.
That is a valid concern.
Yeah, but I mean, they were dramatizing it a little bit. But my question is, why do they use the distinction of tree nuts? Because they're all tree nuts except for peanut.
Right. Right.
Okay.
Peanut's not a nut. It's a legume. It's not even a nut. It's just called a nut. We should call it something separate from that. Although if it's not in the shell, it kind of looks like a nut. It looks like a tree nut. So you can't really tell the difference. So that's why it's confusing. So again, what do you all think about having a handout, a color handout like this that we give to patients when they're diagnosed with tree nut allergy? I think that would be a good thing to have.
It's not going to hurt just passing application is important. Some families will take it, run with it, and use it like a lot. They'll put it in the backseat of the car, just go outside and clean it out. I think it's reasonable. Yeah.
And when they come back for their follow-up, we could give them a little quiz and see if they studied it. Yell at them if they didn't and tell them that you got to learn this stuff.
I think it'd be more interesting to make a little chart that has other things like that.
Yeah, you could just have like an okay or not okay. I'll just say, can you eat that, yes or no?
That'd be more interesting.
Actually, he had the sheet with blanks on how we're going to do that. Then they have another sheet that's behind it that has the answers. So you say, well, here I'm just looking to see if you can identify them. Maybe they'll look at them and then they'll look at that because, gosh, girl, I don't know very many of these nuts.
We might be able to use this exact this very form, actually. Maybe we could continue to add to the research these investigators have done.
The other thing that's hard about this, and it always is going to be, is the dimension. Like when they looked at it, people got to look at it in a display case, so you could see like the shape and whatnot.
Yeah, it was a little easier with the pictures on the screen, but some of these is kind of like, what is that?
We would have to have bigger, clearer images of these nuts to make them easier to identify.
That's not academic.
Very
Right.
interesting. Thank you.
Case you bring out.
So, and you have another one?
Another one.
Okay.
Okay. So my second article is a multi-center retrospective review of patch testing for contact dermatitis and allergy practices. So the objective was to determine whether patch testing results using a limited panel of allergens, such as true test, as compared to an expanded panel, will miss a significant number of positive patch tests. And these expanded panels were North American contact dermatitis panels. The other ones were derma, cosmetics, hairdressing series, corticosteroid series, and personal products from the patients. And the other objective was to compare the patch testing results with the published data from dermatology practices. So some introduction: contact dermatitis is a common inflammatory skin condition secondary to contact with an external substance. The resulting lesions are pruritic and vary in clinical presentation from erythema to edema, papules to vesicles, or lichenification. Of all contact dermatitis cases, 20% are typically allergic and 80% are irritant, as per the references for this article. Only 29% to 54% of the cases can be fully assessed through history taking and physical. Identification of the offending allergens has been shown to lead to an early resolution of symptoms and improved quality of life. And the patch testing remains the gold standard for the diagnosis of allergic contact dermatitis. However, more than 3,000 substances are known to cause allergic contact dermatitis, making the identification of the offending allergens a difficult task. Patch tests are available in ready-to-use, standardized, preloaded systems, which is what we know as TrueTest, thin layer, rapid use, epicutaneous test. TrueTest was expanded in 2007 from 24 to 28 allergens plus a negative control with 5 new allergens. Those are the 5 new allergens. So the advantage of the TrueTest is the allergens are pre-measured and preloaded on hypoallergenic tape, requiring minimal preparation. And disadvantage is lack of flexibility in the allergen choice, increased cost, and the limited number of allergens available in it. The North American Contact Dermatitis Panel is a series of 65 allergens. As of 2009, the number varied previously up to 75 allergens, and they dropped some. It's based on the most common relevant allergens determined through previous patch test data. Supplementary allergens can be used for patch tests, and the testing materials are manually loaded to a chamber. You can use spin chambers or what's called Allergy patch test chambers attached to an adhesive backing and placed on the patient's back. So for this study, what they did was they looked at the charts from between January of 2005 to June of 2010, and they found 427 patients who were suspected of having allergic contact dermatitis, who were evaluated by 5 allergists in 3 separate offices. Patients who were thought to have the allergic contact dermatitis were patch tested to a combination of either TrueTest, the NACD allergen, derma cosmetic series, hairdressing series, corticosteroid series, and personal products. No patients had received oral corticosteroids or other systemic immunosuppressants within 4 weeks of evaluation. They used spin chambers or Allergy patch system on scan-4 tape applied to the patient's back. Patches remained in place for 48 hours, and the sites were evaluated at least twice, so 48 hours and then between 72 to 96 hours later. So the grading scale that they used was what is used by NACD group. The negative reaction is 0, macular erythema 0+, erythema with mild infiltration 1+, erythema with obvious induration 2+, and blister or bullae formation 3+. And I think this is a little different from our true test, but still it's, I think, almost similar findings that they describe. 1+, 2+, 3+ reactions were interpreted as positive reactions. Patient characteristics like age, sex, history of atopy, occupation, and dermatitis site were reviewed. And then they looked at the percentage of patients with positive results to at least one true test allergen, percentage of patients positive to at least one true test allergen, and at least one supplemental allergen. So they called those the partially evaluated ones. And the percentage of patients who were negative to all true test allergens but positive to at least one supplemental allergen, and they called that them completely missed. Final diagnoses were physician assigned, and the diagnoses were allergic contact, irritant contact dermatitis, atopic dermatitis, drug eruptions, other dermatitis not specified, or just other. So the results, they looked at the demographic data, total number of 427 patients, 82% were female and 18% were male, and they discussed that maybe because females are more likely to use a lot of cosmetics or personal products, and that's the reason for higher incidence of allergic contact dermatitis in them. Age, they found that mean was 49.8 and median was again 51 years. So 40s and 50s is the decade of life where they thought that was they should be evaluated for suspected allergic contact dermatitis. They also looked at the history of atopy, and they mentioned that more than half of their subjects had atopic history of atopy, and from the review of literature, they mentioned that if not more common, that it is as common as general population for atopic individuals to have contact dermatitis. So depending on the references that they looked at, they might have found some where it was more common than general population for atopic individuals to have contact dermatitis. And then they looked at the occupation, and they found that the office sales, healthcare, retired individuals included more number of times in their study population. So the site of dermatitis for this study, they found face, eyelid, and periorbital and trunk were the most common dermatitis sites. And this was a little different from the NACD group, where the hands, face, and scattered or generalized dermatitis were found to be more common sites. So for this study group, 30% of the patients were tested with true test, 60% with NACD panel. So they are overlapping. Most of these patients were tested by more than one panel. So 30% are true test, 60% NACD panel, 30% Dormer's cosmetic, 15% corticosteroid series, and 35% were tested with personal products. So these are the most common allergens according to the dermatitis sites that they found. So for eyelid and periorbital site, they found nickel, personal products, and thimerosal as the most common. Face, again, nickel was the most common among all three sites. For the face, fragrance and PPD, which is in hair dyes and tattoos, henna tattoos and all, was another one, and personal products again. For trunk, again, there were some others which were at the third place. Of the 427 subjects in this study, 383 were patch tested to true test as well as some supplemental allergens, and out of them 56.9%, 218 subjects, were positive to at least one true test allergen. 98 subjects, that's 25%, were what they call the partially evaluated, so they were positive to at least one true test allergen and one supplementary allergen. And then 12.5% were completely missed, so they were negative to all true test allergens, but were positive to at least one supplementary allergen. Of the 150 patients patch tested to the standardized allergens plus the personal products, 7% were positive to a personal product but negative to the standardized panel. However, they do mention that just because the personal products are not standardized for the patch test, the irritant contact dermatitis might have been, like the findings could have been more irritant rather than allergic for these patients. The distribution of patients with positive, so when the patients were only tested with true test allergens, they found that 61% were found to have only one positive reaction, 27 two positive reactions, 6% 3, or 6% who had more than 3 allergens that they were positive to. The final diagnosis after patch testing, they found 60% of the times the diagnosis was allergic contact dermatitis, 18 or 19% irritant, 12% atopic dermatitis, 4% were drug eruption, other dermatosis 13% of the time, and 7% they did not find any, so unknown. These were the 10 most frequently found positive allergens, and they compare it with the NACD data. Nickel was still the highest among both of those groups, but the other ones were a little different from what they found from these. This is from more like dermatology practices compared to the allergy practices. So they found fragrance mix and PPD to be the first 3, among the first 3 topmost allergens. Also, the glyceraldehyde and dispersed blue are 2 allergens that are not in the true test. So they found that those were among the top 10. In the 10th place, actually, there was a tie between like 4 different allergens. Those are the 10 allergens.
I think carbon mix is on the true test.
Yes, it is. It's the dispersed blue and glyceraldehyde that are not.
What's dispersed blue, do you know?
It's a textile dye, so in clothes. So the other objective for their study was to compare it to the dermatology literature, and they found that it was pretty much similar. So more than one positive true test allergen for the NACD group was between, or different dermatology practices was 25 to 54%, and for allergy practice it was found to be 56.9, so almost similar. Additional allergen identified with supplemental patch testing, so these are the partially evaluated ones. They found 34 to 52%. In one of the private practices, they found 24%, and ours, the allergy practice, showed 25.6% results there. And completely missed ones, 12 to 22%, and this study lies somewhere in between, so 12.5%. So they were not different. The results were not different from the dermatology literature.
Did they say how they decided to put which ones on which people? Or just is what?
So it was a retrospective. So basically, they just looked at what they had already done, and these were 3 different practices, 5 different allergists. So different people use different series and also. So no, we don't.
It's probably like for the steroid series, it's only 15%. So there are probably people that came in with a suspicion of steroid besides something else.
And then I just wonder if it was like,
there's like a separate panel.
I just wonder if it was excessive, like they put one on and it didn't buy, and so they add another one, or they put all the panels on at the same time. Because it would make more sense if you have a negative true test to maybe pick another
Go ahead
panel
and
if you're really
more.
suspicious.
Right.
Or like clinical history would just make you do more if you had a specific everywhere. Or if it was in a specific area.
Yeah. My experience, I think when Dr. Foxay, who's one of the authors of this, when she's going to talk, she's had pictures of people's back and things like 60 some odd things or whatever on there. So I think some of these people are more inclined to just, you have suspicions, okay, go, this panel I have, I'm going to put this on, I'm going to put this panel on, and just do it once, because she takes a lot of time to come in to be seen and come back, and so if you can get it out of the way in one fell swoop, that'd be better probably for the patient.
So they discussed the limitations that it was a retrospective study. Number of allergens used were varied among the sites and the different sites, and the supplementary panels were not standardized, so they didn't know which ones, who used which and all. Patch test interpretation was physician dependent, and the clinical relevance of the patch test reactions was not evaluated. Strength statistics is a multi-center trial, good-sized population, 427 patients, mixture of occupations to allow for patient and allergen variability. And there are not many studies looking at patch testing results for contact dermatitis in allergy practice, but there is dermatology literature, so this was one of the few. So they concluded that the true test appears to be a sufficient screening tool, but expanded panels may be necessary to adequately assess patients with allergic contact dermatitis. And patients in whom allergic contact dermatitis is highly suspected, but have a negative patch test with limited panels should be evaluated supplementary. So yeah, that's what I'm guessing. Yeah.
Do we do much patch testing in personal products?
People does this all the time.
You put them in fin chambers and just fix them on.
The problem is like Nikki said, that you have to be concerned about are you diluting them or not, and how concentrated they are, because if you take like a shampoo that has 10 different ingredients in it, plus you're taking it full strength and you're putting it in this fin chamber, like how much that's just going to be an irritant, and then even if you get the shampoo, how do you know it's not, which of the ingredients?
Mm-hmm.
There's the people that make banana cream. They have a mild soap that they make that it only has like 4 or 5 ingredients or something in it. And I had a patient before that thought they had these reactions to a variety of shampoos and stuff. And we put this girl on the shampoo, but she still had a reaction or something. And I contacted the company, and they actually sent me all the ingredients in little containers that I could basically, try to make my own stuff on fin chambers. Some of it was hard stuff, some of it was this really like tar-looking stuff, and whatever. But the issue is, again, is like a standardized concentration. You mentioned earlier about the North American something or other. There is an organization that basically has looked at a lot of these chemicals, individual chemicals, and have come up with concentrations that are published of what should be used. So theoretically, if you have like a shampoo or something in it, and there's 6 ingredients that are known to be culprits or on those lists of high priority things, you'd be better off, I think, trying to do those 6 things instead of putting a spot of shampoo on one back. So that's my
Although if you put the shampoo on and it's negative, then you know that it's probably not one of those things. So it might be a good screening thing if you don't have the individuals.
So resolved after the
Yeah, I was wondering that too. If it's an irritant, it should go away.
you can tell if it's an irritant, because it should go away.
Unless it's so strong. Potentially once you take it off the skin, it should be resolved.
So how many allergists actually do patch testing? Is it universal? All allergy practices do it, or do they have any information about that? Because they chose 5 practices that did almost 450 patches. I don't think we do 450 patches in a decade. I mean, that's a lot of patches.
It's very lucrative for private practice.
It is.
Plus adults probably do more than a kid.
Yeah.
Mm-hmm.
So a lot of allergy practices do contact testing?
They probably overdo it.
I don't know.
Let's see their occupation.
See, up until the true test, none of them did it because it wasn't available. You couldn't do patch testing.
When I was in fellowship, we just used True Test, and occasionally if someone came in with something weird, we'd make our own fin chamber sort of thing. And the same thing when I was in private practice for a while. We had before the fin chambers, when I first came here, Dr. Portnoy had this kit, and we had until recently, I think, there was this box that had these syringes that were filled with all these different chemicals, and we used to squirt them in the fin chamber and then put them on people's back. So,
Yeah.
but I think there were more. I think you had more in that box than we have in the traditional fin chamber.
In the true test. Yeah, there was a very large, there were 50, 60, maybe 70 different things in little syringes, and you had to figure out, well, which of these do I want to test for? It was sort of like doing the skin test. You test for the things that seem most likely to be a problem. The problem with that is that it implies that you know what each of the things are and what their likelihood history would be consistent with what they would react to it. I think that our knowledge of contact dermatology reagents is pretty limited because we're given this panel, and so we just stick it on, and it comes back positive for balsam of Peru, and then how many people know what is in what balsam of Peru is in, or what kinds of products? So I think we kind of lose some of the.
Then you look at
Well,
the true
it's
test.
sort of like an idea for a research project. You can have allergists have a list of the contact symptoms, what actually that's what product.
And I
Healing and diazine.
it was hard to find even that information that I included. I was looking up dispersed blue and things like that. It wasn't easy to find, like other, like, you know, it wasn't like.
Well, at least for the True Test, with the True Test site, you can go right to it, and it has each of the different allergens. You can print out your patient handout, tells you what it's in, and everything else. So, I mean, for those 28 or whatever, that's helpful. I don't know about. I've never purchased from those other companies to know, you know, what they provide.
It seems like it'd be more lucrative to do like a personal product one. So like balsam Peru, fragrance, all the things. Because if you come in with your facial distribution, it's probably going to be a chance for a personal product versus like if it's somewhere else, like on a hand or a leg, it may be like cleaning products if you're, you know, beautician or if you're.
And you need to know the history that's consistent with.
You know, that, like you're saying, pick them out, but you need to make panels like that.
You wanted to comment, Brock?
Yeah, just a couple quickies. I really object to calling these things allergens. I think that's a bad use of that nomenclature if we don't know if it's, you know, IgE or if it's irritant, whatever. But when you have 80% of irritant reactions, do you know anything about the reproducibility or the specificity of these tests? Has that, I mean, they repeat the test in a week, and is it always positive, or is there any information on that at all?
What's the sensitivity and specificity of each of these agents?
Yeah.
No idea.
Do we know? I mean,
Or the reproducibility of the test by itself.
We kind of know for immunocap reagents, because those have been pretty well defined. For skin test reagents, do we actually know that for skin test reagents?
I don't know about patch testing to chemicals. The patch testing to food, there have been some studies out of Europe, and they're about the reproducibility for some of these, and like, did you need to redo these tests? And even with some, and actually I think there was even some drug stuff that they did on skin that I think the reproducibility is someplace about 50% or something. And there's actually for some of the chemicals, I was under the impression that they had this phenomenon that if you did serial patching with the same thing over time, you could actually, in a sense, induce a reaction. And it's like they and there's this term they used, like twinkling back or something, which I'd have to look up again to think what that was. But it was something kind of like it's kind of like, you know, you have this almost like amnestic response or something to some of the stuff that you got tested to. So, but it's the reproducibility and sensitivity and specificity for all the patches, I think, is not all that great.
Yeah, well, 50%, you might as well flip a coin.
Well, especially if it's made out of nickel.
Yeah.
Like the activation of the entire area, like just the memory.
All right. Any other comments from the?
Id reaction? Okay.
Anything else? Oh, we had talked last week about the possibility of creating a series of drug patches, like beta-lactam and cephalosporin and sulfa.
Oh, we already have a quinolone. I didn't realize. I forgot about that being added to that 28 patch for the true test that says quinolone.
Yeah.
Well, what was that guy, Dr. Neal, last week was talking in the personalized medicine thing, was talking about patching to antibiotics, because a lot of these reactions are delayed reactions, and suggesting it would be a type 4 reaction that might be picked up with a patch. I'm not sure that means you shouldn't use the antibiotic, because they don't necessarily recur when you give the antibiotic the second time.
But reading them at 7 days after, too.
Is reading them at 7 days. Well, if the patient says, I took the drug and reacted, and 7 days later got the rash, then you want to read it 7 days later when they got the rash. So kind of based on the history is when you want to read it. And if it's on a weekend, they can take a picture and send it in. What do you all think about developing a panel of antibiotics for patching for delayed reactions? Do you think that would be useful in any way, or is it a waste of time?
Well, I guess what's the half-life of it? If you're mixing these things fresh, you have to make, well, you know, what's the half-life? Is it something that, you know, because like penicillin, like we used to do the whole thing about at least leaving some on the counter. When I was a fellow, I used to take some penicillin, mix it up, leave it on the counter, thinking that it rot there for a week, and then to be minor determinant in it. So we used to, minor determinant was gone.
And what do you mean by stability? Immunologic stability or antimicrobial effect stability?
Yeah, or is that going to cause some secondary infection on the patient because there's mold growing on the antibiotic?
Do you? You don't know a lot. But I'm just thinking.
They had their pharmacists mixing it for them, like at the time that they were doing the testing. Yeah.
I'm thinking
That'd be very expensive if you're trying to keep them in your clinic.
Yeah, you can't do that. But I'm thinking in terms of creating a true test like material for penicillin, where we would develop the fin chamber. We would actually make a batch of a bunch of different ones, put them onto the fin chambers, cover them over, and then refrigerate or maybe even freeze them to preserve their stability. So when the patient came in for the antibiotic testing, we would take it out of the freezer, peel the thing off, and slap it on their back, just like we do with the true test. And it might be something worth studying. I think a fellow or somebody who was interested in studying delayed reactions might be interested in or benefit from studying something like that.
Well, I actually talked to Charlie years ago about when we were first doing the food stuff, if somehow we could take some of the food and lyophilize it, so you could have it like a little disc that was in the freezer. You just pull out, stick it in the fin chamber, and then put it on the skin sort of thing.
Can we do that?
Well, that's what I'm wondering about. I mean, we lyophilize penicillin. Is it possible to mix up the whatever the concentration is and freeze it and have it in the size of a thin thing that you could actually just put on the
Why
skin?
does it have to be lyophilized? Why can't you take the lyophilized, put it in Vaseline or some kind of petroleum, which is not aqueous, so it's not like putting it in water where it's going to decay. It's still pretty much dry in Vaseline, and have that already loaded into the fin chamber with a cover over it, so all you have to do is peel and stick.
Yeah, I just don't know what the stability would be if you have lyophilized that, freeze dried that's no longer
Here's
freeze
what I
dried.
would suggest you do, and Brock's going to have the last word like he always does, but when you do your food allergy tests, what I would suggest you consider doing is doing it in duplicates, but having a pre-prepared set of foods that have been prepared the way you're describing, and the other is the fresh ones that you do like you normally do, and just stick them side by side and see if you get the same answers. Because if you do, then you've got one that you can just pre-prepare. Maybe we can even commercially produce it and sell them and make money and reception. I can retire.
Yeah, we talked about it because the other thing is that like we don't put fish on, like a fish mixer, because we want to have this smelly fish rotting on the back.
Lyophilized fish is okay.
So, but the thing, if it's the lyophilized, would that be easier to handle?
But would you think about maybe doing them in duplicate like that and having
I mean, you could do a study like that if you have some volunteers. You could do it, but because right now we do like about 20. That for most kids, especially the little kids, that takes up the whole bag. There'd be no other place to do it.
But maybe even like selected ones.
Yeah, if you did like the 6 major food groups or the 6 things you find most common with the patching, and did them both sides or something.
Yeah.
It's not very reproducible to begin with, so it's hard to say if.
Well, we would have to validate it, but I think it would be worth. There's enough interest in it that it might be worth trying to validate this kind of test. And I know you've been using it for EE, but maybe it's worthwhile looking into it as a test for the test itself rather than just to see if it diagnoses something. Did you want to give the final word, Brock?
Oh, yeah, just a quickie. We did a lot of this with Selner, and we put things in petroleum jelly on patches, and we did find some nice positives to acrylics and things like that. But with respect to your antibiotics, the penicillamine and some of the determinants aren't stable. So you have to either lyophilize them and then take them up fresh, and they change very quickly. So, I mean, you have to make those things fresh.
But what if you mix them, what if you have them lyophilized, put them in petroleum jelly and stored them at -80?
Well, penicillamine and penicillol convert one to each other, in air. And that's a problem with the antibiotics. But
wouldn't that be in an aqueous solution? We're talking about petroleum jelly, which is non-aqueous.
I think it's exposure to air. They're oxidized. But with some of the other things, some of these acrylic compounds and the things that are used in acrylic paints, I think they're fairly stable in petroleum and the jelly, and I mean they might last a long time.
All right.
Yeah.
Well, a lot of food for thought.
Another substance.
As they say. Any other thoughts or comments about this article? That was very interesting. Thank you. All right. Well, we're going to stop there. Again, join us on Monday for our discussion on immunity to microbes. We're also going to be talking about immune complexes. Have a great weekend, everyone, and we will see you next time. Take care, everyone.
This has been an ACAAI production. To learn more about conferences on Lyme allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.